Emmanuel, thank you very much for the nice introduction. And dear ladies and gentlemen, it's an absolute pleasure to talk about the first experience with our Spectral CT 7500 in Heidelberg. What are the challenges for new novel CT technology? It's definitely, we need speed, we need a lack of artifacts, and we need to reduce those even further. And we will also want to reduce the amount of contrast agents. And at the same time, we want to have full and comprehensive diagnostic properties and quality. So we need to detect lesions with a very high sensitivity. And then we want to characterize these, which was translating that we want to increase the specificity of CT at the same time. And you're probably very well aware that trying to increase sensitivity and specificity at the same time is quite a big challenge. And I will just guide you through of our first experiences with the new Spectral CT 7500 for all of these topics. So first of all, this scanner is so fast. This is our new setting, and you will see the turtle, and then the table's gonna move, and it is so fast. And we have a lot of oncology patients who will actually come for follow-ups. And one of the patients asked us whether there was a problem with the CT scanner because it was moving so fast. But it's not a problem. This is what we want. The scanner speed helps us a lot. So, next slide. So we have a lack of respiratory artifacts. This is an example from an ICU patient who was not ventilated. He was not cooperative, so just shallow breathing. And we have super sharp diagnostic images for all of it, the conventional images, the virtual monoenergetic, the iodine maps, and also for the Z-effective map, when we're looking at the lung window setting, no sign of any respiratory artifacts. So this leads us to the perception that we will probably not use any breathing instructions anymore for people who are not cooperative at all. And this will also open the possibility to do kids in the scanner without any breathing instruction, just be fast. With regard to cardiac, we then also have the opportunity to correct for motion artifacts. So this is a retrospectively gated triple rule-out scan. And we have a presence of PE, which is not shown here, but I want to draw your attention to the coronary artery here in the non-corrected scan. And after using the correction mode, you can nicely see that now the coronary artery is displayed very sharply in its full diagnostic. So we have an improved visualization in the combination of high table speed plus correction of cardiac motion. Next point is the dose reduction. So we will be working with dose adaptation based on patient diameter. This is definitely better than not using it at all, but there are caveats with this because we do a lot of staging exams where we have chest, abdomen, and pelvis, and with long scan coverage, just the simple diameter might lead to an overestimation of the chest, especially if you're only using the AP scout, whereas it might lead to an underestimation of dose in the pelvis. So we will work on trying to introduce volume into the dose adaptation protocols. And this is our approach to BMI adapted contrast media volume. So you see these images of a 50-year-old female with ovarian cancer and peritoneal carcinosis. This is the contrast volume. And here we have no adaptation to BMI. Here we adapted to BMI 65, and here we adapted to BMI body weight of 55. And these are the contrast to noise ratios. You can see we can easily reduce the amount of contrast by 30% without losing any contrast to noise. So we are moving to some clinical examples where we found the scanner especially useful. So this was a scan to rule out abdominal hemorrhage. So that's why we went for a quite late venous phase abdominal scan. And we found an incidental PE in the right lower lobe. And if you just look at the conventional image, it is very difficult to have diagnostic confidence and conspicuity in comparison of the right to the lower lobe artery. But when you're using the 40 keV monoenergetic image, it is obvious. It's obvious on the iodine map, and it's also obvious on the calcium suppression image. So with the spectral information, it is just very clear, and you make a clear, confident diagnosis of incidental PE. This is one of the new projects that we are approaching, that we want to differentiate pneumonia from infarction. Again, this is the ICU patient you've seen before with a PE. And the nice thing here is that we have a consolidation here, which might be a pneumonia or infarction. But we can nicely see that there is perfusion in this area. It's not as much as in the atelectatic areas, but it is as much as in the pneumonia areas. And it's not an infarction. So again, here the Z-effective map or the iodine map is very, very useful to differentiate between these entities. The other thing which came as a surprise to us is that we can also contribute much better to gallstone characterization. So a patient with jaundice and a non-calcified gallstone at the papilla frateri, and you can see that it's quite difficult to pick up the stone here, but it's much, much easier in the monoenergetic image, as well as especially here the Z-effective. It nicely shows you the non-calcified gallstone as the obstructor causing jaundice. And this was then proven by ERCP, and treatment was performed appropriately. And just another example, this is a patient with multiple myeloma and fever of unknown origin. And it is almost impossible to detect these non-calcified stones in the gallbladder on the conventional image. It is very difficult. But with the monoenergetic image and with the Z-effective image, it's very clear. Here is a stone and here is a stone. And these are non-calcified gallstones, which are potentially a matter of concern in a patient with fever of unknown origin. Characterization of liver lesions, focal liver lesions, is another issue where we are relying on subtle differences in contrast on the CT scan, which is one of the reasons why we very often refer these patients to MRI, because in MRI we will have more lesion conspicuity based on different behaviors with regard to the gadolinium contrast. So looking at the conventional CT, it's very difficult to map out the lesion here and to have a characterization. But with spectral CT and being fast, we have the monoenergetic image and we have the iodine image and the Z-effective image, and we can nicely map out this lesion fulfilling some of the properties of an FNH. So we will have an increased lesion conspicuity also on a portal venous phase scan using spectral information. And if we have been looking at benign liver lesions, we will also look for malignant liver lesions, especially HCC. And HCC, again, is characterized by arterial hyperenhancement. And moving from a conventional scan where it's extremely difficult to pick up these lesions, we use the 70 keV monoenergetic image for noise reduction to have a smooth background. And then we are looking at the 40 keV monoenergetic image where we are just enhancing the arterial hyperenhanced areas. And we can nicely map out multiple spots which are suspicious for HCC. You see on the effective map, you can also see these as very dark holes, again, increasing the conspicuity and increasing your diagnostic confidence for a multifocal hepatocellular carcinoma. What surprises even more are areas where we would normally have thought of that we have to use MRI to characterize and find these lesions. So this is a patient with ovarian cancer and staging, and we just incidentally found a nodule in the right breast, which at conventional CT is quite difficult to diagnose. But on the monoenergetic image and at the iodine, as well as the C-effective image, it's very clear that there's a hyperenhancing breast lump there. So again, we have improved lesion conspicuity on the spectral data, and this was later proven as breast cancer. This is a patient with esophageal cancer and restaging post-radiotherapy. So this was the chest, abdomen, pelvis scan, and we diagnosed soft tissue metastases. On the conventional CT, no way. On the monoenergetic images and the Z-effective, it's very obvious there are lesions there. And there were multiple, look at this. So again, lesion clearly seen on the 40 keV, not really to be delineated on the conventional. And just more of these. And these would typically be lesions which we would have diagnosed on MRI alone. So again, spectral CT can just answer the whole diagnostic and staging issue without having the necessity to use an MRI scan. Even bone marrow can be addressed nicely. So this is a patient with malignant lymphoma with bone marrow infiltration. And look at this conventional CT. No way that you can diagnose this little lesion. Whereas on the calcium suppression, which is another potential readout of the spectral data, you very nicely see this little area of bone marrow infiltration by malignant lymphoma. So the take-home messages with regard to the new Spectral CT 7500 is the table is just great. It is so fast and it is very comfortable, very easy to operate. So patients and technicians are really very fond of this development. Dose reduction seems to be feasible, and we are expecting to decrease the dose we're using with new protocols that we have been introducing. We also feel very comfortable that a reduction of contrast volume will be feasible, and we are running comparative studies to the usage of contrast with the older scanner, the Icon, and the new scanner. So the spectral information is always there. And all the virtual non-enhanced scans, the virtual monoenergetic scans, the iodine maps, the calcium suppression. So the only thing is you have to decide about your hangings so that these will actually pop up immediately on your workstation in the way that is supporting your workflow and your reporting. Just from the first weeks of using this scanner, we have a very high diagnostic confidence. I was a little skeptical before because I thought, oh, most of our scans are fine, and I don't think that we will reduce the number of retakes or follow-ups or referrals to MR. But it obviously seems to be the case, and we are running comparative studies on this to prove this, that we will do less requirements for follow-up in oncology patients to make sure that a certain lesion is benign or malignant, less referrals to MRI, and also less retakes because of poor contrast or respiratory artifacts. So this scanner is definitely a big leap forward, and we are very happy that we are among the first who will be able to use it. Thank you very much for your attention.